Welcome to another edition of the Harton Healthcare Report. Today we're glad to have Dr. Murphy, a podiatrist here in town with us to do a presentation on common feet problems. Thank you, Dr. Murphy, for being here.
You're welcome. Thanks for having me.
Well, we'll be right back to follow up with his presentation.
Mark, you've won just about everything there is to win in racing. What's next?
I'd like more people to know about ER Extra.
The emergency room at Harton Regional Medical Center?
I just want them to get the best care they can get.
That just gets me right here, Mark.
Maybe you'd like to pay them a visit.
ER Extra at Harton Regional Medical Center.
ER Extra. Extra fast, extra easy, extra great.
I'm Dr. Murphy. I came to, I work with Dr. Bell. I don't know if anyone here has seen him. He's been here for a long time. And I looked over this when they asked me to do it, and I thought the best thing would be, what is a podiatrist? A lot of people aren't really sure because they're different everywhere you go, depending on how they're trained and when they were trained. So I thought we'd go over that and then some of the common things that we treat. So, all right. Bear with me. I have a cold, so I'm a little... Okay, what is a podiatrist? A podiatrist specializes in diagnosis and treatment of conditions affecting the foot, ankle, and lower leg. We do everything from pediatric all the way up to geriatric. We do attend a College of Podiatric Medicine. Most of them are, I think all of them now are affiliated with a medical school. You spend the first 2 years with the other medical students, then they start to pull you out and focus more on a foot and ankle training program. We all now complete a postgraduate residency of 2 to 4 years. Prior to this, most of them were only completed in about a 1-year residency. That explains a lot of the gap in the training. Fortunately for you guys, Dr. Bell completed a 3-year residency, and so you've always had relatively good podiatry at your disposal. Just to give you a comparison, orthopedics does a 5-year residency that focuses on the entire body. We generally do, most of us now do a 3-year residency, that's what I've done, that focuses on everything below the knee. Okay. All right, conditions we treat include dermatological, orthopedic, neurologic, vascular, pretty much everything as long as it is below the knee. Part of these are redundant. Who do we treat? Pediatric, young adults, seniors, everyone. Let's get that again. So we're just going to kind of go through each one of these separately. Skin and nail conditions. We treat fungal nails, otherwise known as onychomycosis. Ingrown toenails, and also abscesses that form around the toenail. Athlete's foot, dermatitis, warts, corns and calluses, soft tissue tumors, and ulcerations due to some form of skin disease. And we'll go over these individually. Okay, nail fungus, which is generally not something that is ever really explained well. It's what happens is everyone carries these on them. Everyone has the fungus their whole life. When your immune system no longer works as well, or if you get irritation from your shoes because your shoes are too small, the fungus is able to take over the nail and just spread everywhere. And I'll just point here since I don't have a laser pointer. Right here is where the fungus actually lives. So that's why most of the topical things and stuff that you can buy at Walmart or Walgreens don't work at all. So generally what we recommend is Lamisil, which fortunately now is generic. Used to cost $300 a month. Now it costs $4 a month. It's just a great big difference. And we always check people's liver. One of the common misconceptions about Lamisil is that it's toxic to your liver and that it will hurt your liver. It is actually less hepatotoxic than Tylenol is. So we just want to know, it's back from when it cost $350 a month, which that's what it cost you. It cost the insurance company even more than that. And so they were always very careful or trying to find a way to not have to pay for it. They wanted an excuse not to pay for it. So they made that up and they would make us check everyone's liver. Now, right now, unless you have a stated liver problem, I don't use it. If you have we check everyone one time, and that's usually more than enough. And I've been using it for quite a while, and I've yet to have anyone have a liver problem because of it. The other thing that can be done, sometimes fungal nails, there can be treated in other ways conservatively, including certain measures that we do to soften them or to allow you to use an emery board on them, all the way up to, and this is Dr. Bell's, we don't do a lot of nail clipping. I certainly don't mind clipping nails if you're in the office already. We just try not to set up appointments specifically for that. Dr. Bell's philosophy, and kind of mine now too, is that if there is a nail, this is not that bad a one, but there are some of them that get really big, and if it's such a big deal and it's causing you trouble and you can't go to get it fixed, and every month you got to find somebody to cut it for you or pay for a pedicure, most of the time the best course of action is just to remove it. We can use it with a chemical, and just never comes back again, and that's it. And for those of us who paint our nails, you can that doesn't include me, but you can paint the skin right over it, and it looks exactly the same. So, all right. So, this is an ingrown toenail. These are either partially or fully removed. It depends on how often you've had them. Sometimes we're able just to remove the corner. Sometimes we're able to remove the whole nail. One of the things I always like to point out with this is that a lot of times, as you get older, your ligaments in your feet aren't quite what they just kind of relax and stretch out a little bit, and the muscles as well, and we'll talk about that when we get to hammer toes, but your feet do get a little bit bigger, and a lot of people don't want to change their shoe size. They've had their shoe size forever, and they don't want to change it, and so if you shove your feet into smaller shoes, then this is what happens. These are relatively easy to treat. We can either do, like I said, permanently or non-permanently, and usually people who get bigger shoes don't ever have these problems again. So, and I practice what I preach. My shoes are much, much bigger in the front. Skin and nail conditions, this is dermatitis in athlete's foot. Most of these are cared for with steroids and other things. There's a lot of undiagnosed athlete's foot that I see that someone else has seen and just kind of left alone. And after a while, it can get to be pretty bad on the bottom. What you're looking for on the bottom of a foot would be reddish colored skin and silver flaky kind of dry skin. And a lot of times that can be treated instead of just left alone. Next. Okay, warts, corns, and calluses. Warts are easily enough removed in the office. It's a simple procedure. Sometimes we can use topical medications to take care of them. Sometimes they have to be frozen. Sometimes they just have to be cut out. The corns and the calluses are a little bit trickier. There's all kinds of corns and calluses. Some of them pop up because of blocked glands in your feet, and some of them pop up because of pressure. For the people who are diabetic or have lost some sensation in their feet, the calluses are the step before the wounds. And a lot of people take the wounds very seriously, but then when the calluses come back, they just kind of, after the wounds are fixed and the calluses are there, they just don't pay attention to them that much. And this is where I'd say 70% of the wounds that I see come from callus that started out bad. And what happens is you get irritation under there, and the irritation builds, and you start to get drainage and inflammation under there, and instead of it being able to get out through the skin, it's not able to get out because the callus is so hard and so big. So it's important to take care of that, and we have all different methods, including accommodation. This is not just a surgical fix. It's we use accommodative things to help lift you up, and just about anything to get it out of the way. Next, okay, and ulcers, since that was on to the next one. And these are actually not that bad, ulcers. People that are at risk for getting ulcers are mostly diabetics. The other ones are venous stasis ulcers. These are ulcers that form on your legs because of excessive swelling. A good way to know if you're starting to have issues like that, there is the darkening. If you've seen someone's legs who have gotten a little bit darker, where it looks like you have a tan just between your knee and your ankle and not anywhere else, that's actually called hemosiderin. It's broken pieces of blood vessel that get stuck in the skin, and it's a sign that your blood flow, your veins aren't working quite as well as they used to, and they're having a little bit of trouble getting your blood flow up. Also, pain or a lot of varicose veins on the inside of your ankle. That's a good sign, and the that your insufficiency is, or venous insufficiency is a problem. For the diabetics, this forms because you can't feel what's under there. And I can tell you that I can't quite see this one as well, but those two were definitely calluses before they were this. So most of these things can be taken care of with diabetic shoes and just simple maintenance and things that we can adjust to make sure that that doesn't happen. Unfortunately, once you get an ulcer, you're kind of at the mercy of how bad the ulcer is and the extent of how far it goes down. Let's see. Okay, orthopedic conditions. There are a variety of orthopedic conditions. We treat everything from hammer toes to ankle fusions. Most of us are, Dr. Bell and myself at least, we try to limit our height to ankle fractures. We usually will do ankle fractures, but things higher than that starts to get iffy with the state board, and it seems like a better idea just to stick with that. Most of the things that we take care of can be fixed non-surgically. And even if they are things that usually have to be fixed surgically, it's always been my policy to at least attempt to do some conservative therapy. I'm always hesitant to tell people when you get done with residency, you want to get out and do surgery, and everybody wants to do surgery. But I think if you were in a good residency, they make sure to point out that the patients don't want to do surgery. You want to do surgery, but the patients don't want to do surgery. So it's important that we're on the same side, and I usually do everything I can, and I have a variety of, I have a little craft shop in the back of my office that I use to fix things up to see if I can avoid doing it. Okay, so we'll start with the first one. Plantar fasciitis. There's a ligament, which you can see right here. That ligament attaches to your heel bone, and this is commonly referred to by a lot of people as heel spurs. The heel spur is actually not an issue. It does not need to be taken out unless you have one that's pointing down. Some of them, most heel spurs are parallel to the weight-bearing surface, which means they really don't cause any actual irritation. What happens is that because of tight muscles in the back of your leg, you are trying to get your heel down to the ground. When you try to get your heel down to the ground, you pronate, which I'm doing right now, but I realize none of you guys can see it. I want to stand up on the podium and do it. But when you pronate to get your heel down to the ground, you pull really hard on the inside of this plantar fascia. That's why it's usually only the inside that hurts. And it'll start to tear right where the bone interfaces with the ligament. And the way the spur forms is, in my opinion, when you have a tear between bone and ligament, sometimes your body is unsure if it's bone or if it's ligament, so it puts down a little bit of both. And that's how you wind up with a heel spur. 95% of this is fixed with conservative care. There are some people that just have to have surgery. There's just no ways around it. After a while, the fibrotic tissue around there just gets so big that there's not much else we can do. Other things that help to take care of this are orthotics. Please, I'll use my time here to not promote the Good Feet store. Please stay away from the Good Feet store. I would be happy to make you orthotics for considerably less money than they charge. And most of the time, the over-the-counter orthotics that you get at Walmart and Dick's Sports and these places are not very good. But we certainly have multiple brands that are good, and a lot of times, the inserts can be taken care of for less than $40. So next. I just wanted to say that before because I've had a lot of people come to my office where they've spent $800 at that store. And okay, this is actually promation. These are things that will help do it. Poor shoe gear is shoe gear that's open in the back. Lace-up shoes hold your heel in a good position, and those are the shoes that we can use orthotics with because they kind of keep everything locked in the back and keep this from happening. Weight gain. Tight calf musculature is the number one cause, and work surface and biomechanical abnormalities. Some people are just born real flat-footed, and there's just there's not much we can do with that besides some surgical fixes. But work surface, if you're on concrete all the time, all day long, this is certainly a contributing factor. Okay, diagnosis. It's usually relatively easy. The standard thing that we talk to people about when they come in, you can see here, this is a relatively small heel spur, but as you can see, it's parallel to the ground. And if it's parallel to the ground, we're not going to get a problem, with the actual spur. When it starts to point directly down to the ground, that's a problem, and that's something that has to go in and be fixed. Those are pretty rare when they do pop up. The number one thing that I hear from people when they have heel pain or fasciitis is when I take the first step down in the morning, it hurts really, really bad, and then it gets a little bit better, and then by the end of the day, it gets a lot worse. So, all right. This just includes other treatment. Stretching is the #1 thing, over-the-counter inserts and changing your shoes. And when we make, these are, the inserts that we use to treat this are functional orthotics. I've gotten away from giving steroid injections, except to people who can't stand to take NSAID therapy. The stretching, the taping, the orthotics, those are the things that actually make you feel better. A lot of times, the other thing that we will use for this that's not on here is, again, night splints are a nocturnal anti-contracture device. Is a night splint that you sit in, and it helps to stretch your leg out while you're sleeping. Again, it's a perfectly viable option. It's not one I use myself, but it certainly does work. The other one is physical therapy. Works very, very well. The therapists do an excellent job with this, mobilizing and stretching. A lot of times what we'll do is let you do it on your own first, and if it's not quite working out, then we kind of send you to them. Okay, hammer toes. Hammer toes are a contraction of your digits. Most of the time, the pain associated with them comes from rubbing, usually right here or right here. There's several kinds of hammer toes and toe deformities, including claw toes, or mallet toes, where the tips of your toes are hitting the ground. And there are multiple ways that you can pad these. A lot of times, bigger, deeper shoe gear helps with them, and it keeps them from rubbing. But the way these form, are as you get older. You have two kinds of muscles. The muscles in your leg are called extrinsic muscles. They control your foot, and those muscles stay very strong. The muscles inside your foot are called intrinsic muscles, and those muscles get a little bit weaker. The way the digit works is that it's pulled on from every direction, so that it stays nice and straight. And once you lose some of the pull from one direction, you start to get these deformities that form. That says here, debridement, padding. Padding and shoe gear change are probably the easiest two things to do. Surgery as an option if it's necessary. Okay, hallux valgus or bunions. Okay, well, there's a lot of these, I take it, from the on. Okay. Okay, a hallux valgus. This is an interesting thing. What it is to us is more movement of this bone. What it is to other people who see it is it's a big bony bump right there, and it's movement of the toe over, and in some cases so much that it's over or underlapping your other toes. The biggest issue that is, I think, when you talk to other people about having a bunion is, I've heard every form of diagnosis and treatment. I've heard that people cast someone up to 3 months for these. I don't think that's necessary yet, but again, that's not anything wrong. There is a lot of different procedures depending on the amount of deformity between these two bones here and the amount that your toe is moved over. It's just a very different thing, so I would encourage you that if you have one and you maybe had a friend or family member who had one and had it fixed, and they kind of told you their experience and that might have turned you off to it, I would consider at least talking to someone about it, because they're very, very different. Everybody's are different, and the ways of treating them are, they fill a good portion of a book that I have. So it's really, really big. And the most important thing to relay to someone who is potentially going to fix it is, what is it that is bothering you about it? Is it when you're barefoot and you're moving? Is it that you can't get your foot in the shoes? Because it's important, if you're considering having this surgically repaired, that you and the surgeon are on the same page about what it is that you're wanting out of this. Usually, again, I do try to treat these conservatively, but the only way to treat a bunion basically is we can move the shoe out or we can move the foot in. So it's got to be one of those two. All right. Osteoarthritis, this is also called hallux limitus or rigidus. This is arthritis of the big toe. This is also sometimes mistaken for a bunion. This is a bunch of bone growth that happens on top of your big toe joint instead of on the side of it. What happens is there's a bone back. Let's see if I got a better picture. This bone here is actually elevated because of a deficiency in a joint that didn't quite make it on the picture. And because of that, this bone butts up against this bone, causing this kind of thing to form here. Again, the best thing to treat this initially, we use anti-inflammatory drugs, and there's an insert. Stiff shoes work really well for this. There's also an insert that will make existing tennis shoes into stiff shoes, because if you're unable to bend the joint, you're not going to have the pain that you experience with this. If you do fix it, again, there are multiple, not quite as many ways to fix these as there are with bunions, but there's everything from removing part of the bone to putting an implant in to just simply doing an arthroplasty to fusing it. So it can be one of a number of things. It kind of depends on the extent of the damage and yeah, pretty much the extent of the damage and the amount of elevation that you have back here. Ankle sprains and fractures. This is something that I just wanted to let you guys know that we do treat this. A lot of people assume that we don't do ankle fractures. I've actually done a lot of ankle fractures over the years, and orthopedics does them just as well. This is usually due to a twisting injury. It can happen. It can break in 1, 2, or 3 places. And again, whether or not it needs to be repaired is due to the amount of fracture that you have and the amount of movement in the bone. For ankle sprains, I'm a big fan of overdoing it just a little bit. If you get into the boot and you're in it for a couple weeks and you get out of it and you're pain-free, great. If you're in the boot and a ligament or tendon has torn that we can't see without an MRI, and you're in it for 2 weeks and you've used the boot, then you really haven't done any damage in the meantime. So that's why I'm a big fan of, because a lot of things, when you come into the emergency room with an ankle sprain, a lot of, they just kind of look at it, and if it looks like an ankle sprain and it's in the right place for an ankle sprain, then they'll call it an ankle sprain. So, yeah, and it's just a little bit better to overdo those. Also, cast therapy, stirrups, all work really well. Ankle sprains can sometimes be more bothersome than the fractures. They can last for quite a while. You can feel like you're really going and you're really healed, and hit a rock the wrong way, and the next thing you know, you're back hobbling again. Okay, neurological disorders. There are a couple on here. We'll spend a little bit more time on the first one, which is probably the most common one. Neuromas are a benign nerve tumor. They occur because these bones right here start rubbing on the nerves. As I said, when we talked earlier about how people's feet get wider, you see these ligaments in here that are down there. Those ligaments start to stretch, and then when you go to put your foot into wider shoes, you compress the bones together, and the rubbing of the bones causes the nerve to grow and get a little bit bigger. It grows fibrotic tissue on the outside, and then it makes it easier to bump into. So the bigger it gets, the more irritated it becomes. And they can occur in other areas, but for the most part, they occur here, which is called the Morton's neuroma. A lot of times people describe this as a burning in their toes that they feel sometimes, and then sometimes they don't feel it at all. And it mostly occurs when you're walking, not at night. Again, multiple ways to treat this. The first thing I would do is anti-inflammatory drugs and to take some weight off the area by lifting up the ball of your foot. If not, the other 2 things we do are, I got it on the next place. You can see it on here. You can see the bone on the ultrasound. Ultrasounds are really difficult to read for anybody, so we usually do a neurolytic injection if the off-weighting and anti-inflammatory drugs don't work. And the neurolytic injection starts to kill the nerve. It's a series of shots, the first one being very uncomfortable, the next one's getting better and better and better, and that's what we use to help treat it and get it down. And if none of that works, they have to be surgically removed, and it's a relatively simple procedure. Other things that can occur in this area, these are just a list of things, the worst of which is stress fracture. From the other arthritis that occurs by your big toe. When your big toe lifts up like that, it often puts extra weight on your second toe, and those bones, as you can see here, are not nearly as big as this bone, so that's what results in stress fracture. This is the treatment with the dehydrated alcohol. We do this at our office. We've been kind of hit and miss because the government has shut down the places where we're getting this from, but I think we now have it again, and we've resolved that problem. Okay. These are just some extra modalities that we do. Bracing and orthotics are for two kinds of orthotics. There are accommodative orthotics. These are the orthotics that you get if you have diabetes or if you've lost sensation in your foot. They have 3 different layers to them. They're really soft. They have a lot of room in the shoe. They let you get around. Functional orthotics are orthotics that hold you up and keep you from pronating and keep your foot from collapsing down. Bracing occurs with a variety of different deformities, and there are multiple different braces that you can choose from or use. Most importantly, just have to make sure that somebody is comfortable with using these. Digital x-rays, diagnostic ultrasound, these are both things that are available at the office that can be done. Usually it is best to have your feet x-rayed at the podiatrist. If you think that you're going to go to the podiatrist, we have special x-ray machines to help to make it easier, platforms to stand on, and we get a better look at your feet by doing our x-rays. And most of the time you wind up having to have another set done if you have them done someplace else. Blood flow. I work with Dr. Drummond a lot, and to make sure that everybody's blood flow is really well. This can contribute to wounds. The biggest thing to be aware of when you're with blood flow is a good sign that you're having issues is walking what's called intermittent claudication. You walk a certain distance and you feel a pain or a tightness or a squeezing in your calf. And if you sit down, it gets better, and then you get up and you can walk about the same distance after that. And that's usually a good sign that there is some kind of blockage somewhere in your arteries. Very, very fortunate to have Dr. Drummond down here. I worked in Chicago for a long time, and I did not always have at my disposal people who were of that caliber, vascular surgeons, that is. Also, Dr. Gupta and everyone here that's able to do, there's a lot of procedures now that weren't available even 10 years ago. They can go in through your artery and do everything through there. They can do bypass. They can do multiple different things. Let's see. Therapeutic shoes, mostly we talked about. The most important thing to get out of here is, especially if you're diabetic, other people that have, diabetic are more of the feet ulcers, and 50% of diabetic amputations were preventable. And the way they're preventable is by follow-up care, by people paying attention to, what's wrong with your feet, what's happening, do I have a callus, does it not look right? That's it. The preventative care is always better on the front end than having to worry about amputating and removing bones and treating wounds, because when a wound pops up, it's never a 1 week and then you're done. And it doesn't matter how good it is, and it doesn't matter how good the doctor is. It's something that you got to deal with for a while, including aftercare and everything like that. So it's not something that you want. Okay, take-home points. Foot pain is not normal. Okay, I agree with that. Most ailments are easily treatable and can improve patients' level of pain-free activity.
Thank you, Dr. Murphy, for being with us today. It was a great presentation.
You're welcome. It's my pleasure.
Lots of good questions from the group.
Yes.
Well, thank you for attending. We'll have another edition of the Harton Healthcare Report next month.